who have just joined. I just emailed all of you the two slide decks from last week's session on the community reentry program within the demonstration and on the directed payments. We ran out of time to sort of sort through some of the more nuanced details of these two projects and how they intersect. And I wanted to pick that conversation back up today. I know that the CBHA had reached out to provide some information because you folks have been participating in some sort of data or reporting regarding intakes with the CBHA. Ashley and I have played phone tag. Roland, I know that you're here with us today, but I didn't know if we could start with if you folks could sort of orient me a little bit to what is in that intake reporting process that you currently have going on with the CBHA. And if we can't, that's okay if you don't feel comfortable jumping into it now.
Yeah, I'm thinking this must be in the 1,600 emails I got back from vacation, so I'm not prepared this morning to jump into
Yeah.
that. I think there was some traffic with Ashley that I need to catch up with her on. I'm meeting with her later today.
Yeah. Yeah. So she and I have just played phone tag, but I guess you folks have some data that you get from the CMHCs. Is there, for the centers, is there sort of a uniform data set that you're all providing to the CBHA for that? Yes, at least Lori's shaking her head. Yes. Okay. Um, and if someone could send me what that uniform, like the data fields in particular, I think that would be super helpful. Roland, welcome back from vacation. So you weren't in the call last week, right?
No, I've missed two meetings.
Okay. All right. So we'll back up just a little bit to orient you, and in case there was somebody here who missed last week's. The Community Reentry Program was approved by CMS to be as an amendment to our current SUD SMI IMD demonstration. That's a lot of alphabet soup. I apologize. So we will be launching that for the targeted date for implementation is January 1st. And there's an element of it that is, pretty significant with the CMHCs. So basically what it is opening up a 45-day limited Medicaid benefit package to individuals who are in the New Hampshire State prison system in custody, who will be released from custody back into the community, hence the term reentry. And what that benefit will look like is the Department of Corrections case manager working with individuals who the Department of Corrections have identified as either having a severe mental illness or a substance use disorder. Those are the target populations that would be participants in this program. Their Department of Corrections case manager will make a referral to the managed care organization. The referral ideally will be going through the closed loop referral solution at some point. I don't know if it will be in time for January 1st, but the managed care organization will be responsible to actually provide care coordination at that point to the individual. Connect with the individual, determine if that individual might have had care providers previously in the community before they had gone into custody, and connect them with community-based providers to meet their post-release needs through a type of warm handoff process. So for individuals who have a history of mental illness in particular, we suspect many of them would be referred to one of the 10 community mental health centers. The individuals will still have freedom of choice. If they don't want to seek care through a community mental health center, they won't have to. They could go into a smaller practice locally, something like that. But we do believe the community mental health centers, along with the doorways, will be sort of key partners in those referral efforts. What we would like to see is if a person is referred to a community mental health center, that they initiate that the community mental health center initiates what we would sort of at this point loosely call the intake process. And that would occur while the person was still in custody through a telehealth appointment. We would also, the vision is for them also to be, to meet like a case manager. So there's a case manager to case manager and the individual having a warm handoff together that way. And also what I don't think we got to last week was a peer, connecting with a peer. So case management, a peer service, starting intake, that is sort of the limited benefit package that we would hope these individuals would receive pre-release. So I'll pause there, Roland, to see if you have a question before I continue to frame out what I want to dig into this morning. Sarah?
Sorry, my last name's not popping up for some reason. This is Sarah Gagnon from Riverbend. Are you envisioning that it's a full intake, or is it a screening pre-intake?
So that's a perfect question. I will get to it in a second. It's exactly what I wanted to try to dig into.
Okay.
Roland, did you have any question first, or should I move on?
No, please move on. I'm still trying to catch up.
Okay, all right. So Sarah, this is where it ties into last week. We started with community reentry, and then the next presentation was about the directed payments. So we will be introducing, as long as CMS approves our request, a new directed payment that is targeted to timely access to services, so that if a person is making application to a community mental health center for services, they would receive an intake within 30 days. And that is worth a pretty substantial directed payment. It is the directed payment itself. All of you have these in your email, the slides from last week now. So let me see, directed payment amount. If they receive that intake within 30 days, it's $2,333. That's the payment that would start out. I won't get into the details of reconciliation towards the end of the year, but $2,333 if there's an intake within 30 days. Now, here's the trick with the community reentry population. We would like the intake process started while they are still in custody, but not completed until they are out in the community. And that is specifically because of the directed payment. The directed payment will apply to people who are in managed care, like fully open in managed care. They won't be fully open in managed care while they are pre-custody. They'll just have this limited benefit. And the directed payment, there's not money in the budget neutrality calculation for the demonstration for the qualifying event to occur while they are still within custody. It would sort of blow a hole through budget neutrality. So we're thinking of this as sort of like a two-step process, and that's why we wanted to talk about it more today, where my understanding is some of the centers have open access and you do the whole intake right then and there. Others of you have sort of a two-step process already where you might use different members of your team to do, grabbing the person's history, things like that. It could be maybe it's a case manager who starts the process, another position, and then the intake gets complete after they are it's gone through the full clinical review and an ISP sign off, things like that. So we wanted to dig a little bit more into that because we're trying to think of what the right approach is so that the incentive associated with the directed payment to give them a timely intake occurs, but recognizing that we need to sort of two-step it because they're still in custody and it would only be telehealth access at first. The 30-day window that we would start calculating for the actual directed payment to happen in 30 days, that clock won't start till the person actually releases. The day they release, they'll be opened up fully for managed care, the full benefit. So if you start it before they leave, as long as you finish it within 30 days of when they leave, it would still qualify for the directed payment. So I'll pause there, Sarah, to see if you have more questions. Oh, Christine raised her hand too. Go ahead, Christine.
I guess what I'm wondering is, and so maybe I'm not understanding it, but we can't really open them up to services until we do that intake. So the issue I'm kind of thinking through right now is how do we have a case manager involvement and be able to bill for that service without having an intake completed and that treatment plan done to then be able to talk about the services. I mean, so I'm struggling to understand how we could even bill for some of the interactions we have with them without having that intake complete.
Okay, that's great. That's that's part of the scenario that we've talked about internally. As I'm this SME from behavioral health in the conversation with our Alvarez and Marcel consultant team and our waiver administrator, and that's part of the what we've talked about is the community mental health benefit is structured that you get intake, you are determined eligible, you get your service plan. Your service plan indicates if you need case management, that's how you get your case manager assigned, et cetera. So there's this very stepped process, right? That stepped process doesn't completely work with this vision of trying to get a meaningful warm handoff done pre-release. So what we would be doing is working through guidance for these specific situations. We sort of similar to when we've made other changes, we release guidance because they don't really align with what the rules currently are. Under the demonstration, we have the ability to be able to pursue this work in a way that's not necessarily totally consistent with our administrative rules because we get special authority under the demonstration for those services. So our guidance would allow for the case management and for the peer to happen pre-release as well. Based on the fact that it is basically a vulnerable population who's already been determined under their current clinical team within the Department of Corrections to have a severe mental illness or substance use disorder. So those would be sort of the underlying basis for the guidance to say it's okay to provide these services right away. And you would be, for the participants in that, you would get a fee for service payment from the MCO. So it won't, that first targeted case management, that would happen while they were pre-release. It's not going to be a qualifier for your per member per month cap, but the day they come out, it'll start that clock for that if they've already become a client of yours.
So Diana,
pause
in this scenario, are we doing like a presumptive eligibility? Because eligibility doesn't typically get determined until they've gone through that intake process. And we wouldn't be able to bill case management without a certified state modifier.
Right. Yes, it is basically like a presumptive eligibility piece. And one of the part of the other issue there, Allie, and we did talk a little bit about this last week, is because the individuals ideally will have been stabilized for quite some time while they were in custody. So they're already under medication management. They've already been receiving some services. We recognize that some of the degrees of impairment that you would anticipate to be able to see to make that eligibility determination, they might not really be present within the time frame that you're supposed to look for those impairments because they've been stabilized. Sort of like if they came out of Glencliff and they were returning to the community, it might be hard to really say, eligibility wise, yes, this person has SMI, because if the impairments have been stabilized so long, they're not going to be present, right? Same kind of concept. We would take that approach and put that in the guidance. The MCOs will be informed as well, so they'll know that you're gonna bill them, you're gonna get paid on the fee for service basis for those services. Jim?
Yeah, Diana, it'd be interesting, given, the prevalence of substance use disorders and you have somebody that's in, Valley Street Jail or prison for a period of time, they've stabilized. Maybe they used in prison, maybe they didn't, but when they come out, it might be challenging for us to identify a level of care based on the ACAM criteria in order to provide services that we think is clinically appropriate, given the amount of abstinence or non-use or periodic use while the individual is incarcerated. So it'll be interesting to see how this flushes out a little bit.
Mhm. Who in the staffing complement at the CMHCs, like which position would best be able to have the conversation that you're basically describing, like that insight with the Department of Corrections care current care manager or case manager? What role would that be?
For Riverbend, we would use our doorway services.
Doorways, regardless if they're well, that's specific to Jim's question on the substance use disorder piece, right? Okay, that's why you would say the doorways.
Somebody coming out, we would they'd go through the doorway, get their ASAM, we'd kind of determine what they needed upon release, and then hook them up with services from there.
Mhm. Okay. Um, what about for other CMHCs? Who would you use? So Nashua, you have a full SUD program operated in your center right now. Who would
Yeah, I'm
Nashua
not sure.
use?
Can you repeat the question, Diana, please? I'm not sure I'm understanding what the question is, what your
So
question is.
Jim,
Yeah.
actually, Jim, will you describe it? You did very well to describe what that concern was that you were raising.
Yeah, just around, when individuals transition from, Valley Street or prison, they may be abstinent, they may have, periodically used. Anyways, based on the ACM level criteria, right? It may be challenging to, let's say, assign an individual that we think is clinically appropriate for IOP when based on the ACM criteria and the level of abstinence may only qualify for outpatient. And I think Diana's question, Maureen, was like, who from the SUD team would connect with the prison when individuals or jails when individuals are transitioning? Is it doorways as well? I don't recall who that would be.
I mean, I think I personally would need more information about how this is going to work because I'm still sort of thinking about I'm trying to wrap my head because we have intake specialists that do intakes for SUD in our intake department. We just added them. And so
Yeah.
For walk-in intakes. And so this is going to be a little, well, not a little, like a process change for us if we're doing I don't know what this partial intake is going to even be because we do screenings if people call us, but we have open access 4 days a week. People are walking in. We're not doing partial screenings. People just come on in unless they call. And then we would do a screening over the phone and then tell them to come on in. So I don't, I don't think that I can answer that. Someone else on my team might be able to, but until I have a clearer picture of how this whole process is going to work. I hear what Jim's saying, like maybe someone was abstinent, I think, while they're in prison or jail, but they weren't prior, but they might be the day they get out. They might not be the day they get out either. So, I think there's a lot of variables to that I don't know that we could answer today, certainly.
And in all fairness, or not fairness, just backing up a minute, Jim, if an individual had the history of SUD but did not have the history of SMI, the MCO is more than likely going to refer them to the doorway anyways.
Yeah.
As part of the reentry and as part of the CCBHC work, we will be opening up targeted case management for the SUD population anyways. And it won't just be limited to the CCBHCs and it won't be just limited to the community reentry. We're literally adding targeted case management for the SUD population. Largely in terms of parity of the systems because we really don't have that. There aren't really case managers in the system, SUD system that can go along a person's full care journey. It's typically If you're going through your residential program, you've got a case manager in the residential program. Once you're back in the community, maybe it's out of your outpatient services provider, et cetera. But there's not really someone who goes along that journey. That will be the role largely fulfilled by Doorways in the future. So Maureen, that part of it, the ASAM screening should happen before someone was referred to ongoing community-based care anyways.
Mhm.
I should have picked up on that a second ago. Jim, I'm sorry about that.
No worries.
Christine?
The other question, so the real issue is the directed payment. So I'm thinking, would we also be able to, let's say, complete the intake and do bill for an intake through the fee for service, but then wait to do a presumptive eligibility, but then wait to do the actual eligibility when they come out of the hospital? I mean, so I'm hearing you say we could do case management, we could do peer support, but could we also do that intake assessment without completing the additional steps that would then open them up to services?
Right, that's exactly what I wanted to talk about, because so
Okay.
Maureen, we don't have all the details worked out yet. That's what I want to talk about here, because I'm trying to recognize that I know the centers do these things differently. Your intake process varies between places. I know what the administrative rule calls for, but if you were to do it in a two-step process, where part of it was begun while the person was pre-release, and then you were to finish it, that finish line, what would that look like for folks? What would, if you're designing it, let's try to design it together. What would that look like? Because I heard in the last meeting that in some centers, a case management position might be the one who's starting the intake process. Not do the full thing, but maybe do half of it. In other places, the intake might have all done on the same day, like open access, and you might see 2 or 3 people as part of the completing that full intake process. So that's what I'm opening up the floor for. Sarah?
So what we were envisioning is that we would have somebody do the telehealth while somebody was in prison, but the part of the intake that they would do would be the ANSA. So they would complete the ANSA while somebody was still there, and then wait to actually bill for the intake, so the claim drops, so then you can get the directed payment, and that would be the full biopsychosocial.
Okay, so do the ANSA while the person was in custody, and then complete the full intake process post-release, the balance of the intake process.
That's what we were thinking. Yeah.
I guess what I'm thinking though is what is going to be triggering the directed payment? So I guess what I'm saying is it when you're completing the eligibility and opening them up, or is it the completion of an intake? Because if it's just the eligibility, which is then doing that piece, then we would probably, I mean, I think people are going to do it differently if you have the option of case management versus peer support versus whatever. But I guess I would be curious is what is actually going to prompt that directed payment. That's what I would really like to.
It's the completion of the intake process.
Yeah, so
Well,
one
not
of
the
my,
process, but what actually,
What
it's
data
not,
element?
it's not the assessment, I'm guessing, that we're billing for. Would it be the fact that we complete the eligibility and then now they're identified as eligible for services, or what? Do you understand what I'm saying, Diana?
Right, it's less, it's, so right now in the administrative rules, right,
Yeah.
there's the eligibility part and the
Yep.
intake.
Yep.
And unfortunately, the way it's written, it sort of cross-references over itself, and it jumbles a lot of it all together. And I
Yeah.
think that from my perspective, for the centers, what's the final part of what you consider the intake process? Is it the development of the ISP?
I mean, we do the intake that includes the ANSA. It's a comprehensive document, right? And then it has a preliminary treatment plan on it where we would be ordering. So I'm also wondering about, I'm assuming if we're only doing an ANSA, we don't have to, we're going to do fee for service for these services without a treatment plan. Because,
Pre-release, yep.
right, but we won't, like, we're required to do a treatment plan to provide services, right? To get paid for services. So
Well, we're
an
gonna
answer,
write the guidance, we're going to
Okay.
write the guidance, Maureen, in a way that doesn't require the full ISP to have been done pre-release,
Great.
because you need to
What-
complete the full intake after.
Yeah,
So we'll make
yeah.
some new, some provisions for that.
great. I'm just pointing that out. These are
Yep.
the things that I'm kind of thinking of as we're sitting
Okay,
here.
sorry, yeah.
So no, that's okay. So we don't need a treatment plan. We won't need a treatment plan, or there'll be alternate guidance. But I mean, one of my concerns is if the payment is triggered at the completion of the treatment plan, of the completion of the intake that's done post-release, what if the person doesn't follow up once they're released? I mean, that happens, right? So then we would have put time, energy, and work into it, and then we're not going to get paid for the ANSA. And the ANSA is it's not a small document. It's not, it's a significant amount of time that someone would be doing on that telehealth appointment.
So
Without-
that appointment would be paid on the fee-for-service basis.
Okay,
So
okay.
even if they don't complete it, then you lose out on the directed payment,
Okay.
but you still get paid for what was actually delivered.
Okay, great. Thank you.
What would we be billing
Thanks.
in that first appointment when we're just completing the ANSA?
That's part of what we want to talk about. That's exactly why. Because what we did is we put into the budget for it approximately the dollar value of a 99,205 E&M appointment. But that's like the dollar value for just that appointment. That doesn't include the dollar value for the case appointment, case manager, contact, or the peer. But that's why we want to talk about what codes, what would that service look like. Steve? Oh, it's very hard to hear you, Steve.
Sorry, I have microphone issues. My
There you
question is what I'm concerned about is the trigger point for, when do we go? So how are you going to capture that in the standard process across all 10 centers? The other thing is, in order to get the process rolling, we have to set the person up as a client in our system,
Mhm.
right? So we got to assign a client number, we got to do all that stuff to get them going. So that has to occur before we do an answer, before we do an intake. So what's the trigger point? I can capture that consistent, standardized, consistent across all 10.
Trigger point for the directed payment or, okay,
Yeah.
so, I know you joined us a little bit late. What we talked about is as long as the intake is completed, the full intake process is completed within 30 days after the person releases. So, well, there's a 45-day window pre-release that they can receive the initiation, if you will, of the intake process. Now, maybe that's the answer. I really like that idea. And then the day they release, we'll start the 30-day clock as long as the CMHC finishes the intake within that 30-day clock. It would qualify for the timely access directed payment of $2,300 and change.
So you'll get the date of release from the prison and attach that to the
Yes.
CMC,
Yeah,
attach
so
that to
the
the centers?
prison, the DOC will coordinate directly with the MCO. The MCO will be the first point of contact with that person, with the resident and the case manager for DOC. And then identifying if that person appears to need SMI services or meet SMI level of care, they're going to discuss connecting them with the CMHC. If the person is agreeable, then the referral from the MCO to the CMHC will be made.
Steve, I was actually thinking what could be interesting. So when we do the intake, it's the intake assessment, it's the ANSA, it's the eligibility, and then it's a treatment plan. That's like what we do for intakes. So my fear is that if we split up actually completing that intake assessment into two, like you're saying, that could be hard to track. So in my mind, what I'm thinking could happen is we do that intake assessment that has the ANSA, then we can dispo the patient because we've done that clinical assessment to identify the appropriate team. And then we could assign them to the team. So once they're discharged, then the treatment team could then complete the eligibility and then do that treatment plan. So like we're saying, I think it's breaking up the intake, but in my mind, I wouldn't actually break up the intake assessment because I'd want to be able to bill for that fee for service and get them dispoed. But then we wouldn't do the clinical eligibility and the treatment plan until they came, because then that should probably then prompt that directed payment because of that eligibility that's completed, because you would go from the presumptive to then the actual. In my mind, that's what I'm thinking the workflow could look like.
Brittany?
just so people are aware, if they're not, the individuals, even though the MCO will be making that referral, when you connect with the DOC, right? If it's any substance, even if they're going to the doorway, but maybe they also need mental health, you're going to be able to get a full, like their LADAC is going to be doing a full assessment. So you will have that information. They're doing the ANTS as well. And they're looking at eligibility through the case managers based on the current CMHC eligibility. As in, Heidi Guiden has gone through our rules. She's reached out to a few people, including myself, to make sure the diagnosis. She did ask if there was particular forms, and I explained that everyone uses their own form. But if there were forms like for CTI or things like that, or from New Hampshire Hospital, some centers have a form that they want completed, right, upon referral, they would be open to using those. So you will be doing your own ANSA and things like that, but you will be getting, unlike possibly a lot of people you'll be getting, right, treatment plan, current psych plan, meds. I mean, you'll be getting a very neatly wrapped background and current presentation using the same standards that you guys are going to be looking at. So they're really trying to match that up for you to make it easy, smooth, and everything is in the same format. So yes, you'll still do your own answer, right? But you will have a very updated one that shows certain things. You'll have a treatment plan. You'll have a psych social if you want it, because they do one as well. So you'll have all that history things, and you'll have the same assessments, just so when you're thinking about what you're going to do and how much time you're putting in, know you're going to get a good amount of current documentation for whoever's, making that initial contact with the person, which should hopefully help with some of that administrative things where maybe you'll spend less time tracking down some of those things. They're going to give it right to you.
So if you folks were, let me just sort of try to pull the room. How does the concept of having the ANSA done as that pre-release appointment to have that be the first part of the intake, how does that sound to folks? Seeing some shaking heads. Let's say it this way. Is there any center that would have a concern about that being the approach?
I might. I'm trying to follow this. My potential concern would be you have an answer, if I heard this right, that was going to be done by somebody in the prison, and then we're going to do one. What
The
if those?
center would do the ANSA.
Oh, we're doing the answer. So
Yes.
Okay, I thought I heard somebody say that there's LADACs they're going to be doing the answer in the prison.
So no, so in the prison, right, they're already receiving services, and part of the services that they receive, right? So when you ask for their current clinical documentation, you're going to get a biopsychosocial, a treatment plan, their full psych history, full med history, and an ANSA. And then if there's any substance, you will get a full LADAC evaluation. You'll get an ASAM. So you'll still do your own. I just wanted people to know that
They'll be
on
sharing
that
the
end of
clinical
tracking down all
information.
that supportive
Yeah,
documentation
so
and
they are
are
gonna
things
do an
up to
ANSA.
date. They
Yes.
do them
Well,
there
this is what
now.
we're putting on the this is what we're putting on the table now. The CMHCs for that pre-intake appointment to start as part of the intake process, doing the ANSA. That
No,
would be
I get that. I think I just heard Brittany again say that somebody else is doing an answer before we get there. Yes or no?
Yes, but it's not your
So
ANSA. I
I
was
know
just
it's not
letting
our
you know the
answer, but the answer is
documentation you'd be
isn't it
getting.
the same answer, or isn't it a statewide answer? So my concern is you get two answers that are not congruent, right? That's my concern if we go down the path that way. Otherwise, I don't really have any concerns.
okay. So the ANSA wouldn't have necessarily been done right before they're going to release, right? Brittany, these are people who would have been doing an annual review of the person. So it might be a 10-month-old one, it might be a 5-month-old one, it might be last month's.
I
Right.
just mean you'll be getting a good amount of history documentation, which then would hopefully help your intake process and your team process when you're thinking about, right, are they going to need center level of services? What level will they need? Because you're not going to be, in theory, doing a lot of face-to-face, right? So that's just more of what I was trying to let people know, is that you're going to be getting a good amount of historical and documents that will be easily translatable to your current staff. So hopefully that will reduce some of, your intake staff's time, right? Because they'll be looking at things that are very familiar to them, and they'll get a good picture of how someone is, but in a controlled environment, right? Which is why you'll be still doing your own ANSA and things like that. It's because obviously the environment is going to play a difference in possibly how they're acting or,
I'm not completely
responding.
convinced as to why the answer would be done at that stage. I'm not fully bought into that being done before they come into our system. Fully into our system.
Okay. Go ahead, Chris. Sorry.
It just strikes me as it could be more confusing than it's worth having the other answer done.
They have to do it yearly. So I guess when you request records, if you don't want their last treatment plan, if you don't want their psychosocial, if you don't want previous ANSAs or their medication evaluations, and you don't have to take them, right? I just wanted to throw it out there that, because sometimes getting those supportive documentation can be a time suck, right? For staff to track down all those things. And one benefit with this particular population is their staff has already tracked all those things down for your staff. So it doesn't change anything. It's just that process of the intake where normally you would be reaching out to previous hospitals or previous providers. You're not probably going to have to spend that amount of time doing it, because they would have already done it for you because they were incarcerated, and that's part of what they do.
In our system, it's not necessarily the same people who would do eligibility that I would see doing this outreach role, this an initial outreach. So I'm not sure it would work great for us.
Other suggestions then, Lori? Because it's okay. I really want to hear from, what's the optimum direction we could all live with, because that would be the best, right?
I mean, our center's thinking that even leaving it open to where if there's some centers who want to break it down where they do an initial appointment, right, via Zoom, and maybe they do the ANSAs fine, but other centers are going to use that initial appointment just to make contact, get a face-to-face, explain their maybe open intake, or right, explain what they're going to do if they're not giving them an exact appointment, and then collect all that information. And then do, your normal intake process when they show up at your door, right? Maybe leaving it open for both, given, right, centers do things differently.
I like
would
doing the
think
answer
that if-
because it'll, go ahead, Jay.
I would think that if we're looking to create a new system, that the goal should be that we do something where the centers are, as much as possible, initiating the same workflows, and that we need to sort that out. The last thing I think we want to do is have 10 different ways that we're implementing this.
Which is why I'm having the conversation. Thank you.
I will say we don't even use the answer, so that's another thing for Westland. We use different tools.
So
I like
Diana,
doing the answer. I keep interrupting the CEOs. Go ahead, Lisa.
oh no, I'm not Seacoast.
No,
He
CEO.
said CEOs.
No. I just feel like I appreciate the fact that you're trying to be able to get people's consensus. I just feel like the experts are really the operational people who know how each one of these steps would impact the other. And before we get too far down this road, I really think that those are the folks that should be meeting to say, this is how we can make sure we're all doing the same exact thing when we take people to reentry. And not so much, well, I think coding and billing always follows. But right now, I don't think we have the sequence of events figured out yet to even understand the coding and the billing.
Okay, fair point. We can dedicate next Fridays to bringing different people to the table to continue, and if that helps. Because that way it's already in the schedule, Lisa, or we could try to set up a separate meeting for that. I'm game either way. I just want to make sure, even though this isn't until January 1st, the directed payments, if they get approved, it's for September 1st. And many of you folks know those directed payments sometimes get approved months after the period has started, but it goes retroactive back to September 1st. So as we're building the logic of what's going to count as a completed intake within 30 days of application, I wanted to have some insight into what this particular approach to it, the community reentry approach to it, would look like, just so that we don't develop guidance that is not already thinking about January. Steve?
It's kind of old, but I was going to say that I like doing the answer first because we use it for eligibility. So it'll establish eligibility before they're released.
Okay.
Right.
Folks were to do the answer, or Lori, the what your center uses, I forget what your center uses as the alternative. Is it the
DLA.
Dartmouth one?
We use the DLA.
The DLA, sorry, thank you. So if that were to happen in one session and not a complete intake, what would that be? The psych eval, the 90791 for $169, $170, is that what that normally would be? Tricia? You're on mute if you're talking, Patricia.
Oh, I wasn't about to answer your question.
Oh, okay. You were just going to answer something else, ask something else?
Sorry, I was, just something that aligned with what Lisa said. And I just want to say that I think we have to take this out only because right now, everything that we're talking about, whether it's operations and QI, but whatever the workflow is, currently, it doesn't really align or support in the way that the HEMs are written or have been drafted. And so I think we, like, those two things also at some point have to come together. So we're not driving sort of a workflow that is not aligned with the draft that we currently have out there. From what Jen and I are aware of, it doesn't align right now. So I think that with what's being discussed. So I just think we have to also consider that. That's all.
So Patricia, in we're looking at merging, if I'm correct, 401 and 408 under those draft rules. Are those the drafts you're talking about, or are you talking about 426?
I think it's more 426 at this point in terms of what's considered like an intake assessment, what's, and what we're even kind of contemplating or talking about isn't really addressed in terms of what we've been taking a look at, because it's been quite focused on kind of how to integrate some of the CCBHC language into the rule versus what we're talking about here, which is taking a separate type of assessment and creating that. So.
So the good thing is I think we're all aligned that we want whatever we do pre-release to flow nicely into the post-release system, right? And certainly take it back. Lisa, do you think we could just invite different people to this meeting next Friday, or should we schedule a whole separate meeting?
Certainly, whatever you think would be worth it. I think that if you got a smaller group of the operational people though, and said, this is how it works, and this
Mhm.
is how, and really let that be hammered out and come to some consensus about what the flow will be, then we have a product.
Mhm. And generally for the other operational people that maybe aren't the ones that are joining these Friday meetings, um, would 9 o'clock Friday generally work for folks, you think? I mean, unless they're off, of course.
Yeah, I think we could make it work. My person that I would really want at the meeting is on vacation next week, so wouldn't
Okay.
be able to make it. My intake director. And I imagine there's a lot of vacations this month with
Right,
people's teams.
right.
So a little more warning than the week might be helpful.
Yeah, okay, so let's schedule it out for probably 2 Fridays from now. And I'll take that Friday appointment. So let me go in here real quick just so I can.
So who would you want to have there? You'd want to have operations people, and did you want to have the quality people?
QI, yeah. I was gonna say
Operations
QI.
and quality. Okay.
QI needs to be, I mean, and
Yeah.
some of us might choose just to have our QI. That might be
Okay.
plenty, right? Because, I'm confident Jen can represent the intake process because she just had a big old intake QI team with that whole group. So, just so that there's, I can minimize the number of people. People are so busy and there are vacations. So I'm like, for us, I'm fine that if Jen's here, she can represent both sides.
Okay,
So that's a really good point, Patricia. Should we be identifying just 1 or 2 people per center and just getting the, that? What do the other CEOs think if it's just 1 or 2 people per center?
I would say so. I think the bigger it gets, it's just going to be very difficult.
Yeah.
I agree.
Okay.
Okay, so the next Friday is the 23rd. There's a lot of vacations. The 30th is the beginning of the Labor Day weekend. There will be a lot of people off that day as well, including me. That brings us to September 6th. Kids are back to school. Generally, vacations are done. How does that sound? Okay. All right, then we'll do that. So what I'll do is I'll just update the January 6th invitation, the narrative, the people who are normally on here, hopefully they'll read it. They'll say, okay, I don't need to be at this one. My executive director is going to identify who's going to come to this one. You can just forward that invitation, or do you want me to start a totally separate invitation and just cancel the Friday one?
I'm fine with forwarding it.
Okay, great.
Yeah. And then we can identify who we're going to have represent the organization.
Okay. I'm just putting some notes in there for us to sort of track back. I know that we have the recording, but sometimes it's just faster for me to see things in my team's site. So let's go ahead and do that. Regardless of how we completely work it out, intakes in general, so separate the community reentry. Intakes in general, I believe we have experience under the current directed payment because we have timely prescriber. We have a directed payment that's associated with timely prescriber after a person receives an intake. And we have the codes identified for that already as it's going on. So I think we have the data that captures what the centers currently use for identifying that that intake appointment has happened, because that's the starting point for the timely prescriber. I believe it's the 90791s, 90792s, and there's some E&M codes as well. If anybody thinks between now, because we're not going to have this other meeting until September 6th, that there would be a different code than the 99200 series or the 9078182, can you shoot me an email and let me know? The other thing is if you would you have ideally that And so whatever that screening is, wherever we land that, would that be a case manager that you would use for that, or would you use a different role? Think about that again for that September 6th. So it's not just the what we would want to call it, what's in that scope of what they would do, what code would we want to land in, it's who would be doing it, because we also have to think about making sure we try to get a case management connection pre-release. And then there's also peers. So in time for January 1, if not earlier, our goal was for September 1st. I don't think we're going to get there, but sometime between September 1st and January 1st, we want to open up the peer support service under the community mental health benefit. It already exists under the substance use disorder benefit. It's a 15-minute unit, would be the same price. There'll be an individual and a group one. So that is also part of this vision for the community reentry. So those, I just want to plant those seeds for that next meeting. I'm going to share screen again, just pulling up that one slide on the directed payment piece of it. You folks can see my screen now, yes?
Yeah.
Okay. All right. So if the timely, just sort of to reiterate this, if the timely access happens, not just for the community reentry, for all of the other new application to timely access, a timely intake within 30 days, there would be this trigger the timely access 23. If they then were to get the timely prescriber appointment within 30 days of that intake process, that would be eligible for another $404 directed payment. The act, the being able to count them the first member month that they're out, again, that would start to trigger that third directed payment, the act related payment. So there's quite a bit that we want to make sure we're lining up in terms of coding and sequence to help stimulate that. And I just want to recognize, Jen, you know, the work that we're doing on that timeliness standard as associated with the CCBHCs. We do recognize that, you know, CMS has changed the timely access standards for 2027. So we have until 2027 to get to that 10 days across our entire system, not just the CCBHCs. It's supposed to be 10 days period, but across our entire system, we have until 2027. So our thoughts are, let's make a nice glide path to get there. So we start the directed payment incentive at 30 days. Then next year we would seek it at 20 days. Then the final year we would seek it at 10 days. So we're lining up in time for when we need compliance across the system. So that's sort of the logic behind that. All right. I think that's what we really wanted to try to dig into today to continue that discussion going forward. One thing on the peer support services there, I did have a conversation with the waiver team yesterday to confirm one concern that we had. There is interest in peers who have lived experience in involvement with the justice system. You know, for many, many years in the past, individuals who were releasing from the prison system were provided essentially parole requirements about not interacting with other convicted felons or certain convicted felons, things like that. So how would that longstanding practice intersect with this intent right now, or hope that peers have lived experience in the justice system also, if they're going to become a peer with someone coming from community reentry? We confirmed DOC doesn't have that position. They've worked hard to get rid of that position. So that should not be a problem. I don't know how many of you folks have peers that do have lived experience also with the justice system, but I'm sharing that with you as you're sort of thinking forward in the future. It doesn't mean they have to have lived experience in the justice system. It just means that we think it might be ideal because they'll better relate to what that person's experience is going to be like when they're returning to the community. So with that, we have 3 minutes. I think we, if there's no questions or comments people want to raise, we'll open up the floor if there's anything else to surface for now. Okay, I hope you all have a great weekend. Thanks for joining today, and thanks for the collaborative conversation. We'll get there.
Thank
Bye.
you, Diane.
Thank you.
Thank you.